think people will start. Thank you very much. Got it. Always love that. Got it. We got the recording in progress. So thank you all again for those of you who have taken time to join. I'm Bob McNellis. I'm Senior Advisor for Primary Care here at the Agency for Healthcare Research and Quality. And we are excited to bring you sort of one of our last sessions in this primary care learning community, at least as of now, which is on such an important topic. So in many ways, we definitely save the best for last because this is so important, and we have such a great panel lined up today to talk about and hear from. But most importantly, I want to make sure we hear from you, all of you in the primary care community who have joined this to share your experiences, tools or resources that you have used, really to hear from that. So if we go to the next slide, Elizabeth, one thing that will help us as we work through this is get to know who's on the call. So as you join, if you could, put in your name and where you're from, what you do, just really keep it simple, just so we have a sense for who's joined us and who's on the call, and that would be tremendously helpful. Now, if you go to the next slide, Elizabeth. Here's what we have planned for you today. It's a lot, but I think we can get it all in. First, I'll start. Here I am welcoming you all. And then we're going to hear from the director for our Center for Evidence and Practice Improvement, Arlene Bierman, in just a moment. And then we've put together a panel of 3 speakers who each come at this from a slightly different perspective, whether it's the individual, whether it's what to do in an institution or organizational setting, or what to do more broadly across organizations. So I'm really excited to hear from all of them. And then we're going to have our question and answer and our discussion. And for part of that, we invited a special guest. We've invited Mark Lindsay, who's been a longtime grantee of ours and done a lot of work in improving working conditions for clinicians to start off our discussion. And then really, we want to hear from all of you who have joined. So. And then the last thing, so we're going to end that discussion after about an hour, but we've tacked on about 15 minutes. For those of you who can stay, love to hear from it. Since this is our last session, we're going to provide just a really high level of what we heard and provide large thanks to all of you who joined us over at this. If you could just go on mute, perhaps. If you're not on mute, there's a little bit of feedback coming through. And then once you're on, we can turn your mic back on. So if you go to the next slide, Elizabeth, with that, I'm going to hand it off to my boss, Dr. Arlene Bierman, to give us a few welcoming remarks. Arlene, all yours.
Yeah, so welcome everybody. Thanks so much for joining us, and thanks so much for joining along this whole year. And, I'm really excited about the session today on clinician and staff well-being. And we couldn't have gotten a better panel or, presenters for this discussion. And, I just wanted to say we have learned so much from all of you over the last year, both about the challenges you're facing, your responses and solutions. And, I think that primary care is really at a crossroads. I think COVID really pointed out how critical primary care is and how under-resourced it is. It hasn't gotten the same attention as public health, but it's gotten some. And I really do think we have a little window of opportunity to advance both primary care delivery and primary care research. And AHRQ is really trying hard to expand its primary care portfolio. And we want to stay engaged with you. We know this is the last session of this series, but there's a number of opportunities coming up. We'll be reaching out to you. We're really especially interested in clinical preventive services that have suffered because of the pandemic and patient-centered care planning. So stay tuned to us. And we really just want to, stay on at the end if you can for 15 minutes, because we do want to hear from you about, what we could do better, what your needs are, what worked well, and really ideas for the future. And, just thanks again for joining us.
Terrific. Thank you, Arlene. Appreciate that. And I echo my appreciation to all of you for joining us over the year and for today. So I'm just going to set us up so that we can move into the panel with 2 quick slides. And the first one, if you go to the next one, Elizabeth, is nothing that all of you haven't heard before, and that really we are facing an epidemic of burnout and fatigue. It was already difficult in many primary care settings where people were feeling burned out, depressed, anxious, and fatigued. COVID has certainly made it worse. And you'll hear much more from all of our speakers about not just what the problems are, but actually some solutions and thoughts about how to do that. But but this is this is just headlines from the past week, so that we know how big of a problem this is and how important it is that we address it. And if you go to the next slide, I did want to make one extra point, because we're going to hear a lot about clinicians today. And apologies for the busyness of this slide, and I will include a link to this article in the chat. But we're also concerned about not just burnout and fatigue for clinicians who are on the front lines, but also many of you in the audience work with primary care practices closely, and maybe you're a practice facilitator or a HIT advisor, and you still have to work through that emotional labor of doing your job in the face of real stress and challenges. And that really, as AHRQ thinks about practice improvement and how we continue to do that in the face of the COVID pandemic, focusing on facilitator resilience. And when you have to work with very stressed clinicians on a daily basis, your own stresses come into play there. And that we're not going to really talk about this today, but I wanted to let you know that we were extremely interested in thinking about not just clinician well-being, but also how this applies to practice facilitators and those of you who support primary care practices. And if you go to the next slide, Elizabeth. What I'm going to do now is actually the hardest part of my whole day here, and that is try to synopsize tremendous bios of these really talented people who we've brought to share with you their perspectives on this. I'm going to introduce the whole panel, and then I'm going to turn it over to Katie, as long as once your connection is good, and then we'll just roll through the panelists if that's okay. So first, let me just give you some brief oversight of who you're about to hear from. And Dr. Katherine Gold is Associate Professor at the University of Michigan in the Department of Family Medicine and Department of Obstetrics and Gynecology. And I pulled out one thing that really I was interested in out of your extensive bio, and that is also that you're medical director of Luke Clinic, a free prenatal and infant care clinic in Detroit. And my family and wife are from Detroit, so I have a lot of connection with Detroit. So I was excited about that piece. Also joining us is Dr. Lou Baptista, who's Associate Professor of Psychiatry at Columbia University Irving Medical Center. Here's my favorite thing about you, Lou, is that you've been appointed as Chief Wellbeing Officer for Columbia Doctors. And I think that what a great title, Chief Wellbeing Officer. Also joining from Columbia is Dr. Claudine Mellons, who's a clinical psychologist with clinical and research expertise in psychosocial aspects of HIV disease and substance use and stress in children, adolescents, and young adults and families. And actually, Dr. Mellons is also co-director of the HIV Center for Clinical and Behavioral Studies, which actually speaks to how really different conditions can really drive stress and behavior in different ways. The third of our panelists is Joelle Monaco, and Joelle is the Director of Outreach and Business Engagement for the Mental Health Association in New York. Actually, and one of the things I saw in Joelle's bio that I really identified with was she really focused on the integration of well-being in organizational culture, in operations, in benefits, in leadership development, and people engagement. This is actually needs to touch every facet of the organization. And then our guest discussant today is Dr. Mark Lindsay, who's the M. Thomas Stillman Endowed Chair and Vice Chair for Education, Mentorship, and Scholarship in the Department of Medicine at Hennepin Healthcare and a Professor of Medicine at University of Minnesota. And he runs the Hennepin Healthcare Office of Professional Work Life. And is it work-life balance, or will we actually ever achieve balance, Mark? But that's okay. That's a rhetorical question for now. With that, Katie, I'm going to hand it off to you to lead us off with your remarks, if that's okay.
Thank you so much. That was a lovely introduction. I will say I am recording this out of a basement clinic room in Flint, Michigan, where we're opening a second prenatal care clinic. So that's why my internet's been a little bit unstable as I try this. I'm really pleased to get to talk about this, and I'm talking without slides, which I never do, because I mostly wanted to tell some stories. And so Bob McNellis asked us to talk for 8 or 10 minutes. He wanted to know about experiences in primary care, especially with COVID. What I did find out is he didn't intend for me just to admit that I'm a family medicine physician and then cry for the rest of my 8 to 10 minutes of the talk. He wanted something a little bit more optimistic. So I'm going to try to share that with you today. All I'm going to say about burnout to start is it's bad, it's everywhere, there's more in primary care. I don't need to tell this audience all the different statistics about how much and who it affects. I just want to say it's bad. I was asked to talk about individual perspectives on burnout, but I really see burnout as an institutional issue. You know, if you have burnout at work, you go home and things are much better. You feel much better. Burnout is really about institutions. So what I want to do is focus on how burnout is affecting people in these institutions and talk about some of the research that I've done in this area. So primary care is in a weird position. We weren't the frontline heroes like the ER docs, right? We weren't saving lives and intubating people. I mean, some of you might have been, but most of us were working at home. Our offices got closed. Anything that wasn't urgent got shut down. We started doing televisits. We started doing phone visits. Patients started contacting us through the portals and sending messages. And all of this came on top of already being frustrated with the electronic medical record system, with disparities in care, which just got worse with COVID, now with delays in preventative care, a lot of hostility around the science of COVID, and staff shortages everywhere. So everything that we want to do requires more staff. And the problem is we can't hire any of the positions that we want to hire. And this is going on across the country. So my entrance into burnout was that my chair asked me to work on wellness in the department, which sounded great. I did a little survey and we were at about 33% burnout. And his goal, he was very number oriented, he wanted me to reduce it by 5% a year. So now we're 5 years later, our burnout rate has almost doubled to 50%. So I will be looking for a wellness job if anybody has one, because I'm clearly not going to make it for long in my department where it's just been rising astronomically. When I started looking at burnout, most of my research is on physician mental health. And I thought, oh, how different is burnout? And it's totally different. And I thought, who has done research on this already? And I went into the business literature because I thought, well, surely they try to keep people happy in the business world, right? They pay them a lot. They try to keep employees happy. There was very little written about burnout in that literature, even though I tried to read it pretty extensively. And what I realized is that hospitals and health systems and clinics are most like nonprofit organizations. So when we're reading outside literature, we should read about other nonprofits. So what do I mean by that? We are not generally here to be motivated by money, certainly not in primary care. I have a colleague in plastics in Beverly Hill, and I'm sure he is motivated by money, but none of us are doing this because of that. So why are we here? We are here for the same reason other people are at nonprofit institutions. We are here because we're doing work that we feel is meaningful. We want to make a difference. We enjoy our colleagues. We find the work stimulating. All kinds of things that drive people in nonprofits. So when I've been thinking about wellness, I started to think, what works? What is it that makes a difference for people? So one of the things that really makes a huge difference is individual flexibility. And businesses talk a lot about this, and nonprofits, but schedules matter. We can't necessarily pay people more money or even what they're worth, but schedules matter. And they matter for physicians, but they also matter for all the rest of the staff. You know, if you think about our medical assistant staff and our clerical staff, they're not making much money. And they often have the least flexible jobs of all. And yet we could be giving them so much more flexibility in their jobs, which would increase their own sense of control and satisfaction. But very few people are doing that. So I think that's something to think about. I also found I happened to be interested in telemedicine before COVID hit because I had read a couple of stories that suggested that for physicians, it might save them time to do a televisit rather than meeting somebody in the office. So I had a project all teed up to go, and then boom, COVID hit. And I thought, oh, this is a good opportunity. So I started my study. More than half of the people had never done a televisit. And what we found was that more than half of people felt like their telemedicine visit saved them time compared to in the office. On average, 8 minutes. So that's a lot of time per patient. And so while we're all talking about how patients don't mind being seen by televisit or the care is comparable, I think we also ought to think about telehealth as potentially helpful for physicians and other clinicians who see patients. I think it's nice to be able to cook dinner while you're also talking to a patient and being able to take little breaks in between, have a little bit more work-life balance. I also think we need to allow schedules to be flexible so that people have time for physical health checkups, for mental health days. I actually read about one nonprofit that says to people very explicitly, you can take off if you're sick for physical reasons or for mental health reasons. And others just give wellness days as sort of built into the system. And I think those are flexible strategies that we can use, and we can use with everybody in our offices. The second thing is about prioritizing meaningful work. So you're probably familiar with the work out of the Mayo Clinic about if physicians spend at least 20% of their time doing what they find most meaningful, that will help with burnout. I think in general, we ought to think about what it is in our work that feels most meaningful to us. And that's part of the reason that I'm here in Flint this morning, is because this is the most meaningful thing that I do. When I was surveying our faculty, I thought, well, I'm part of the obstetrical group who does labor and delivery, and babies are quite ornery and they never are born at convenient times. And so we're there day and night, and we stay up all night, and we're supervising residents. And I thought, I'm sure this is going to be the group most unhappy and most burned out. And I was quite surprised when that was not the case at all. In fact, that group was hardly burned out at all. And I really thought long and hard about that and realized this is about doing what's meaningful and what people find rewarding. And if it's rewarding, it actually can overcome those other inconveniences, like being up all night, which is not the nicest schedule. But thinking about what we do in our practices that brings meaning for each staff member, what is it that they enjoy the most, and trying to focus on that, I think, is helpful. I think the other thing is in primary care is patient relationships. That's what we like to do. We don't want to spend all our time clicking buttons on the EHR. We want to talk to our patients. And there are also a lot of gender differences, which I've written about. Women and men see different patients. So you all know women are more likely to come into the office. Well, women see more women patients. Women tend to spend longer. You said you spend longer if you're seeing somebody of the same gender, whether it's men and men or women and women. And women are twice as likely to bring up emotional content with other women as compared to men. So I met a colleague at a conference, and she said, oh yeah, I was talking to my colleague and I said, Mrs. So-and-so is coming in, and we'll end up talking about her depression for a long time. And he said, depression? She's never talked to me about that. And it was a really good example of just how different our worlds are, and not better or worse, they're just different. So there's different content and different amounts of time. And so I think thinking about the gender differences is really important. I had a couple who came in, they wanted to see each other's checkups because they were newly married and they were doing everything together. So I did the guy's checkup, and the woman was like, oh, okay, that's interesting. And then the woman needed a breast exam and a pelvic exam. The guy was like over in the side of the room thinking, oh no, this is too much. This is too much. So it's just different. It's different with men and women. And I think thinking about that in cultures is also important. How do women physicians interact with medical assistants who are predominantly women? How do we interact with clerical staff? What are the differences? Again, it might not be better or worse, but they're different, and we need to think about that culture. I think another topic I want to mention is the patient portal. So in our department, the number of patient messages initiated by the patient and sent to the doctor have more than doubled since COVID hit. And so literally we're in the thousands now. And there was just an article in one of the JAMA Network Open publications in October that said primary care physicians get an average of 46 messages a day. And that is 100% more than surgeons. It's 50% more than a specialist. So this issue of patients wanting to contact their doctor in some form, even if it's not face-to-face, is very real in primary care. We don't have any extra time to manage all of that. It's great that right now we're getting paid for that, but that has to continue because patients want that continuity. They want to know what I think about them getting a COVID vaccine or what I think about them taking a certain medication. And to do that, I need the time to be able to do that. And I'm just going to talk about a couple other sections here to keep it brief. I think empowering staff is a really critical piece. I did a big survey looking at our medical assistants across 6 clinics. And interestingly, I asked them about seeing their role as a calling, because we know that for physicians, feeling that your role in healthcare as a calling is protective against burnout. 95% of the medical assistants saw their role as a calling, and they really saw themselves as the orchestra director in the clinic. They were the ones who determined how the clinic flowed. And some of them said, I feel valued. I want to make my doctor's day go well because they value me. And others said bottom of the totem pole, and people don't. Clinicians need to think about these cultures and how we treat others in our practice. And often those who are making the least are the ones who really need other things to help support their satisfaction and reduce their burnout at work. I know Dr. Lindsay just published yesterday, I think it came out in the Annals of Family Medicine, an article that talked about clinics that have high levels of trust, both for patients and clinicians. And those organizations value quality, communication to be all about. We get distracted from and we're pulled away to. Issue to just mention is, I think, in addition to work flexibility, we need to build in boundaries to our work. So what I mean is, in my department, a lot of us don't take our vacation. We should. I know I should. But here we are in November. I'm scheduled out in clinics through April. I don't know when I'm going to schedule in a vacation because I'm already like being scheduled with patients, right? And I feel guilty if I turn over my inbox for someone else to have to manage. And I feel guilty if I cancel patients. And I feel guilty if someone else takes my call. What if institutions, they're very quick to tell me if I haven't signed my notes, or to have what we call the epic screen of shame, which tells how good were you at responding to your messages in 4.5 seconds when they popped up. They send me those screens of shame all the time. But what if they sent me something saying, you have 22 days of vacation left. Have you scheduled that? What if quarterly I got a reminder about my vacation? What if my chair, do this last week, said, you guys aren't taking your vacation. You need to do that. Set those examples, but we also need boundaries. We need policies that say you are required to take your vacation, or you may lose it. You are required to sign out your inbox when you're away for certain days. We need things that make it easier so that we don't have to rely on our own guilt. And we just have a sense of boundaries at work. So I think that is all that I'm going to talk about. I'd be really interested in the comments about things that others have seen in their clinic that have worked in these realms, since I'm going the wrong direction in my own department.
That's terrific, Katie. Thank you. And thank you for working through your internet connection in the basement in Flint. But great remarks, a lot to chew on there. A quick note to participants, put your comments, observations, thoughts in the chat. Really appreciate that. So thank you, Katie. Now I'd like to move on to Lou. Lou, would love to hear about some of your work at Cope Columbia. It's all yours. And thank you, Elizabeth, for firing up the slides.
Thank you, Bob, and thank you for the opportunity for being here, not only to share, our journey, and we're at the very beginning of our, journey at Columbia, but mostly to get feedback and listen and learn. I wish I had a whole 45-minute therapy session with you guys, because certainly Claude and I need it. So, but I'll try to make the best out of our, 8 minutes. So what I'm going to do, I'm just going to show the first slide, and then if you can actually just, share, the screening. I prefer also the conversational, mode, especially for 7-8 minutes. So Cope Columbia is the program that we put together at the very first week of the pandemic, and it was our attempt to really try to support our system, our medical center, during a time of unprecedented, crisis. So Cope Columbia is really comprised of a core group of psychologists and psychiatrists that we hand select at the very beginning, that really donated, their time, and providing, a whole gamut of resources that we're going to talk a little bit more about it. Cope Columbia, for our, luck, really, got a lot of traction very quickly. And the name Cope Columbia has really now become very widely, known as a branding at the medical center, and even expanding throughout, the university, has really opened a lot of doors, has really, helped us make a lot of partnerships, and certainly, acquired a lot of street credit, and created a platform to really start looking into not only providing resources to individuals and small groups and units and departments, but really start looking at culture and at the systems level. And that's the evolution of Cope Columbia that I'd love to have, input from you guys, because for us, although I don't know if it was a punishment or opportunity, that was asked to become Chief Wellbeing Officer, but I don't see myself as an expert in well-being. certainly, I think I'm in very early stages of my learning process on that. So I really love to have, some feedback. So before I talk more about Columbia, let me give you the background, because it was not just random. It was just like, let's call Lou and Claude and create something. So about a year and a half before, the pandemic hit, Columbia Doctors, there's the Faculty Practice Organization of Columbia. It's comprised of about 1,800 physicians, has a board. I had been elected, for the board about 4 years ago. And at the end of one of the meetings, about a year and a half before the pandemic, I raised my hand and asked about how about the opportunity to start looking to physician well-being, burnout, work experience as an opportunity to optimize performance, retention, and then work experience. And, that took a little bit of traction. The following month, I was then asked again, whether it was punishment or not, to then, lead a task force to look into that and come back to the board with recommendations. So the tactic at that time was really to try to make that peer-driven, faculty-led, not top-down. And we, had representation from most departments, people that were already interested in that space. And we moved very quickly into doing focus groups and got really qualitative data from a wide range of faculty from different departments, junior, senior, female, male, underrepresented minority. We wanted to do some surveys, but at the time, the top leadership of the medical center was not eager to quantify morale and engagement or other issues related to work experience. So we settled with focus groups. So that focus groups led to then identifying 5 buckets of priorities that the faculty basically delineated. And as we started to move into making recommendations concretely of about those 5 different buckets, including, for example, community and connections. People want to have physical spaces and processes to then facilitate relationships. That's one of the top priorities at Columbia. The other one was improving onboarding experience to really imprint people positively from the beginning to Columbia. So that's what kind of feedback we had. But as we moved into, let's get now into recommendations, the pandemic hit. So when the pandemic hit, there was already a movement, a momentum in a relationship and enough trust that, the dean called us, Claude and I, and so we need to do something. And that's how Columbia was born. Claude and I and another colleague, Laura Mayer, who was the medical director for house staff mental health at Columbia, got together. And then the next day, Columbia was launched. So we initially went live with 3 main resources, offering one-to-one peer support. We made a case. This is not psychotherapy. This is not psychiatric treatment. It's a peer supporting another peer. And we had 7 days a week, several hours a day, people call a number, and through Zoom, they'll be connected to one of us. And at the time, Zoom was the best thing in the world. So we had that. We also had very similar model, but instead of one-to-one, small groups, leveraging the peer experience, and was very customized. So we run for several months, and still not until recently, weekly meetings with the physicians for the emergency room. We had bi-weekly meetings with the LBGYN faculty. We had frequent meetings with the ICU nurses. So we really customized, and we always did things in teams of 2, the small groups. And then the third resource were educational town halls and webinars. And we could have a town hall for the medical center with hundreds of people. We could have a town hall for one department with 30 people. We could have one of us talking a university-wide forum with 2,000 people. But I think really gave us a platform to really start to create a messaging around well-being, around validation, around active listening. And really, again, trying to create a momentum for a culture of wellness that was so important, during that time. So we also create a website with resources, videos, content, links, Spanish translation, and that was put on the central website for the medical center. We continue to add and develop the website. And for several months of the pandemic, the small groups were the #1 resource utilized. followed by the town halls. Some weeks we're running 20, 25 different groups for different, teams, running, 5 or 6 town halls. So, and followed by the one-to-ones. The one-to-ones, we also learned that 25% of the one-to-one sessions led to linkage to clinical care, that people really need beyond peer support. They need to have formal clinical care. The other evolution of Columbia is that our psychiatric services at Columbia became primarily a Columbia employee service now. The good news is that they trust us and they're all coming to be seen by us. The bad news is that we don't have capacity. So we have this huge waiting list, and they're all Columbia employees. And, and we have no subsidy or support from the medical center, from the hospital to support mental health services for the Columbia community. So that's another, we did not foresee, this outcome. We started to really get into this organizational, angle several months ago, initially not by design. Now we're trying to be a little more intentional. And we saw opportunities and gaps such as the sequential transitions that the staff was going through and the high level of stress the managers were enduring, and not having the equipment really to, to support, their staff, having difficult conversations, conflict resolutions. And then we started to focus, interventions, workshops, small group discussions with managers, and creating some toolkits, for example, during the election times, and how to manage and facilitate conversations during the political divide that we're going through, and then the first holiday season of the pandemic, and then the racial stress and all the heated conversations were happening, and the managers did not know how to, react and manage that. And so we started to really trying to help and assist, at that level. We then were asked to go and assess a team of 300 staff. They felt was burned out. Those are revenue cycle people. They're critical for the financial health of the organization. It was really organizational consultant kind of job. That was really meet with them. We did surveys, we did focus groups, we provided feedback, trying to stay in our well-being lane. But certainly you're going to find leadership issues, management issues, communication issues, culture issues that were not necessarily in their well-being lane, but clearly, there was an opportunity, to start getting to this more organizational level. So as a sequence in June, then the chief wellbeing officer, role was created. So I think was an attempt to the medical center recognizing, I think, the value of having resources for faculty and staff. So the ask from me was, can you take their role to continue the services, but also develop the position, right? And that's where we are right now. I think one of my first interventions, and Claude has been there all along as my partner and advising and influencing the medical center, is that we request every departmental chair to nominate a faculty well-being leader. About 3 departments had. Most departments did not have any formal support or organizational around well-being. And now we have a well-being leadership team of 33 people, including the communications department, HR, faculty affairs, the EMR, department as well. And we just had we only had 2 meetings, since July. We're meeting monthly now, but we already very quickly broke up in 3 work groups, and Claude is co-leading the metrics work group, which I think was the most important. And they're going to be giving us recommendation next month about our very first attempt to establish baseline metrics at the medical center at the systems level, utilizing a combination of already validated scales, but also creating customized pulse surveys that we can really integrate the Columbia experience and go deeper in particular areas that the validated scales might not necessarily get into, too much. We have a subgroup working on defining what well-being means to us at the medical center, and creating a communication and messaging strategy to influence the culture of well-being. And a third subgroup working on identifying gaps and needs for resources and activities at the systems level, in addition to Columbia. So, has been a very meaningful journey for us, has been transformational, but we're just beginning, and we don't know what we don't know. So we'd love to hear feedback.
That's terrific, Lou. Thank you. Wow. And Elizabeth, do you mind going to 2 slides ahead? Because there was one slide you had in your deck here, Lou, that I think we don't need to linger on it because I do want to make sure Joelle has time. Go another one. It's the tree. I actually love the idea of the concept of growing resilience and wellness, not just in individuals, but in organizations. So I don't know if you or Claude
Sure.
want to say a moment about that. I'd love to just so people can see this.
Claude, why don't you comment on it? Because you're so good when you talk about the tree.
Thank you so much. This has kind of become our logo and also just a constant reminder to everybody about actually many of the topics that Dr. Gold, you were also referencing, as well as what we've been doing at COPE Columbia. This was created by one of our psychologists, Anna Allman, and really it's highlighting 9 evidence-based strategies for coping with stress, with challenging life events, from the resilience literature as well as the mental health literature. And we really teach these in much of what we're doing, but it's here for everybody to remember. And I think both the speakers talked a lot about this, and this is a lot of the work that Lou and I do with COPE Columbia, giving people permission to reflect, to think about their values, which was brought up before, to engage in self-care. And that's getting harder and harder. People are getting, I would say, burnt out on hearing that they need to engage in self-care, but it's just as critical as it ever was now. And we could all share stories about that. Hope, without hope, we need to reconnect with our values, but we also have to have hope for the future. And then gratitude, which I think you've been doing here as well in this group. It turns out that the expression of gratitude to others is actually associated with physiological stress reduction and improvements in mental health in a number of studies. And you can see other things here, and forgiveness and learning to not just be forgiving of others, but also of yourselves. None of us have been at our best in this pandemic. So that's our tree and a really nice heuristic for remembering these things.
I love this tree, actually. And just if there can folks access this online anywhere, Claude? Maybe we can put a link in the chat. And I want to acknowledge that there are some chats going on there. Vacation seems to be one theme. Take your vacation. And so I love that. And actually, the other thing about the tree is growing strong roots in the organization is an important part of the stability of the tree. And actually, that might be a nice transition to our next speaker, because I want to hear from Joelle also. So Joelle, why don't we roll ahead, Elizabeth, and give Joelle the floor, and then I can't wait for the discussion here.
Perfect.
Well, all yours.
Perfect. Thank you. Then first slide, please. And I do have some slides just because, I know we have some visual learners and we have auditory learners, but the conversation today has been great. And there's definitely going to be some reaffirmation of some of the topics I'll be talking about, but it's why sometimes I like going last, because we can thread it all together. And while, we're talking about burnout, we're talking about high stressful situations, it's really important to point out that 51% of our health status is based on our lifestyle and 20% on our environment. So this is something that we can influence and we can change, and we can build lifestyle changes and through resources and services. And it sounds like a lot of the work being done is exploring some of these, but these are things we can do individually and organizationally. And a lot of times when I'm going into organizations or working with individuals, there might be different, needs, and there might be different views. So even though your organization might not be taking on, big lifts like we're seeing from Katie and Lou, doesn't mean that you personally can't integrate well-being into the workplace. So I'm going to talk at it from 2 kind of perspectives, being individually, but also organizationally, because we don't want to say, okay, our organization isn't bought into this well-being, so there's nothing we can do. If we are, let's start from the top. With human capital planning, a lot of organizations that I go into and work with, the first thing I'll ask is, what's their budget for human capital? And most of them don't have it in a business line, right? When we're doing annual planning, we budget everything, but there's not an actual line in most cases for human capital, unlike Lou talking about chief well-being officers, which is a great addition to any business, because that is really fully integrating well-being into part of the organizational culture. So I'm sure they have it in theirs, but most small primary care family physicians, they may not have this built in. So making this a priority and working from a strength-based and really looking at what is individual development, but also what's the organizational development goals, and looking at that from a multi-dimensional well-being perspective, not just focusing on, those walk programs and things that are so standardized, but really looking at it from what are the social determinants of health and how do we make everyone feel engaged, involved, and taken care of in the workplace. And what I really like, Lou pointed this out, combining a variety of professional levels to give you feedback. Many times we see operations and organizations come from the top down, not fully assessing what is the impact of that operation. A lot of times when I'm going in, I'm looking at operations and thinking, okay, how do the people fit into that operation? And how does this impact their well-being? But when we're creating that operation, we're looking at efficiencies, time reduction, and all of those things, especially in the medical field. So when we bring in collaborative groups of variety of different, roles, 10-year experience, we can really unpack and we can see where those areas of opportunities might be needed to reduce stress and unnecessary stress that we might be causing on our team, for lack thereof, just not asking, right? And finally, when we're really planning for human capital, I always say creating a budget. This is not just an initiative that can be thrown into the HR team, right? This is something that has to be ingrained in the culture to really be successful if you're looking at this from an organizational perspective. And really integrating human capital into our operations as a business initiative, not necessarily just something that we do as a checkbox, which I think COVID-19 has done a great job bringing well-being to the forefront as not just a nice to have program, but really a business essential, as many of the speakers today have alluded to, and many of you in the chat have alluded to. This is something that's integral to the workforce. Next slide, please. So here are some practical applications that we can all take part in today, whether organizational or individual. And, when we're looking at these, it's easy to look for something that we can be grateful for today. And I love the tree. This talks about a lot about between the tree and the next two slides, but finding something we can be grateful for. And this can be done at the start of morning meetings. This can be done on a virtual team board, whatever it is that your team has, expressing gratitude, because studies show that people that express gratitude actually have better health outcomes than those who don't. More importantly, individually, lead by example, right? Creating time for yourself. To Katie's point about taking time off, we can feel really guilty, but imagine if we're not taking it, what that says to our team. Right? If we're not taking it, our team may also feel extra guilty for not taking it. So, sometimes we have to prioritize ourselves because we model what we see. And if we have a team following us or we have peers, we want to make sure we're actually modeling the behaviors that we want them to carry out. Another one is getting to know one another. This seems really simple, but most employees that experience high levels of burnout or stress in the workplace report that they don't feel as if anyone in the workplace actually truly cares about them as a person. So this is that part of that getting to know one another and really building those personal connections beyond just, hey, this is my colleague, right? Additionally, turning off. I know for some of you, this may be really difficult, but turning off when you have the opportunity and truly disconnecting, because that allows our bodies the time to restore and really our minds to reconnect and build that creativity that we need for problem solving, quick thinking in the workplace. One thing that I think is really great that some organizations are doing, because now we've spoken to it in many of the fields that and individuals are supporting, are working on a variety of different schedules. Some organizations are actually putting a clause in the bottom of their email signature. And it says, should you receive this email outside of your normal business hours, please don't feel the need to respond. And the reason being is we recognize we have people working all different times across different time zones, but we want to give everyone the opportunity to not feel that stress of, oh my goodness, the senior VP sent an email at 8 o'clock at night, I need to respond. But really put it out there and say, sometimes we all work on different schedules. So we'll find, and to Bob's point, there's no balance, it's called integration, right? Where find that integration that works for each person on your team. And then when we look at it organizationally, it's been alluded to, implementing policies that support employee well-being and begin to normalize the conversation that it's okay to not be okay, and make well-being conversations part of the daily culture. Maybe you start one-on-ones, our team meetings, talking about what did you do for self-care. If we're making it a priority and talking about it regularly, it becomes something that will become ingrained and over time will start to build into people's routines. And given the topic we're discussing today, creating policies in your employee handbook. We have a policy for everything, right? How long are some of your policy books? You know, it's a chapter. We're going to discredit it, but if we're going to really say stress and burnout are really a high priority in our organization, let's put a clause in our handbook that says we take it really seriously. Here's how we handle situations of high stress and burnout. And here are organizational services and resources that can support you. Because then it takes away that experience that this is only happening to me. And we know data shows it's not only happening to one person, but when you're experiencing it, a lot of times people see it from the outside and don't feel as if everybody else has these moments of overwhelming feelings of stress. Another is been brought on by COVID-19 and the civil unrest is the need for bereavement services in the workplace. Even though maybe your team didn't experience any loss, there's a lot of different types of loss that we've been experiencing over the last 2 years. So see if there's, through your EAP, you might have this service already available. You can bring individuals in for individual sessions, or maybe you do a group session for your team to really meet their emotional needs where they are and allow them the time to unpack and process things as needed. So these are just examples. I put this up here to give you, a plethora of things. I wish I could go through all of these, but there's, a lot of times it's not recreating the wheel. It's just looking at the wheel a little bit differently. And when we do that, let's look at, how we can integrate these policies. Ooh, next slide. Sorry, I forgot. Thank you. Into a multidimensional approach to health. A lot of you are probably familiar with SAMHSA's 8 dimensions of wellness. And this is really something that when we're talking about well-being, we can continue to build resiliency from a multidimensional approach, not just necessarily focusing on one piece of a person, right? And thinking about it a little bit differently, because for physical, we can actually look at, do we have an occupational therapist or a chiropractor? What types of shoes are our teams wearing? Do they have the adequate equipment on their body? And how can we make that life easier? Financial, bringing in a financial advisor, right? To talk, that might be a service already available through our EAP. And then practical application. I heard a lot about this, about how do we balance everything? Employers can find practical application in transportation services. If we want people to take care of themselves, we have to give them the time to actually do it. So can we create a carpool system? Can we do laundry services on time? Can we have a group grocery drop off? So it takes these few daily activities off of people's to-do list. So when we're saying go home and take care of yourself, they truly have the time and the space to do it. And last but certainly not least, next slide, please. I'll highlight the integration, and I was really happy to hear this. Doing good doesn't always equate to feeling good. So the fact that primary care teams are doing really great work doesn't mean that they necessarily feel happy. So we can influence our happy and mindset. And there's 4 chemicals that include and increase happiness. And you see them here on your screen. And these are things that we can integrate into the workplace. I'll give you an example for each, so I can just wrap up and we can get to the group discussion. Dopamine, eating healthy food, taking breaks, right? Oxytocin, giving a compliment. Serotonin, meditating, or just getting outside. And then last but certainly not least, endorphins are released through laughter. And that could be watching a funny movie, telling a joke, or even those terrible dad jokes will fill the void here. So when you're considering, integrating a well-being plan, be sure to really look at what can you do from all of these perspectives and the variety of views to really make it fully integrated, but also part of your organizational culture. And last but certainly not least, there's my contact information if anybody has any questions.
That's terrific. Thank you, Joelle. Really appreciate that. Wow. Great presentations, great remarks by all of you. Thank you so much for doing that. And thank you. I see the chat is going. I'm going to turn now to start the discussion. In order to do that, I'm going to turn to Mark Lindsay in just a moment. But actually, I'm going to throw something in the chat because I have a feeling I want to make sure that everyone's saying what they're thinking. And it's what one thing will you do tomorrow to support your or your colleagues' well-being? Think about what you've heard today and what you're going to do, and would love to hear some great ideas about what you're going to do tomorrow. And while you're doing that, Dr. Lindsay, let me turn to you to react to what you heard today, and given your body of work, help us make sense of this from your perspective.
I am so thrilled to be here, Robert and Arlene and everyone. Thank you so much. What an honor. After 20 years of support by AHRQ and 4 studies that seem to have gone by in a heartbeat, the MEMO study, the longitudinal study of practices and work conditions, and the Healthy Workplace trial, the randomized trial of workplace interventions to reduce burnout, the MS squared study to reduce stress in the electronic record, and currently our learning health system program. I couldn't be more grateful for these opportunities to try to make an impact. So thank you all for letting me share. I heard a lot today that I think is really terrific. And I'm going to start with Katherine's schedules matter. I think probably nothing matters more to people during their work lives than their schedule. It really matters. If you take away control of people's schedules, you take away everything. So they need to have some control of their schedule. And the phrase we use is, if you standardize, customize. So if you have to standardize from 8 to noon, make sure to customize it for somebody's childcare or family care or other responsibilities. Glad to hear about televisits, saving time. I've always found that. I think they're great. We have an article, we think, coming out shortly about telehealth equity, improving access for racially minoritized groups. So I'm in favor of them. And gender differences, so grateful for your mentioning that. We have several articles that we've written about that. And one of the things that we emphasize is just what you said, Katherine, about the length of time that women physicians may need in the office is longer. That's been shown for 20 years. And so we actually believe you need smaller increments in visit times, 20, 30, and 40 minutes to allow that extra increment of time. And we've even gone to customizing compensation plans, adjusting for patient gender. So I think there are ways we can do this. In terms of Lou's comments from Columbia, spectacular. I took a lot of notes. Peer support programs. We did a buddy program during the pandemic that was very successful. We got it from Albert's article on a program from the military institution at the University of Minnesota. And the pulse monitoring, we have an app that we've been piloting that hopes to accomplish what you're doing there. We think that's terrific. Once a year burnout surveys is what we've been doing. They're tremendously helpful, but there's nothing like having information in the moment. So we agree with that completely. And what a great tree, resilience tree. That's marvelous. Joelle, thank you for so many things, particularly the individual versus the organizational. As I try and teach everybody, the data are convincing. They both work. We don't have to argue which one works. They both work. And so why would you not take advantage of both when you could? So there are individual preferences, and system change is probably better, but it sure takes longer and a lot more work, and you can't do it yourself. So while you're advocating for system change, individual is great. So then I just thought I'd mention, Robert, sort of what's new, what I see happening on the horizon in this work. We published 3 or 4 articles now on the Coping with COVID study. We've looked at 60,000 healthcare workers across the country. And we've learned a lot about not only physicians, but also nursing assistants, social workers, food service, a lot of frontline people, social workers who have had a lot of struggles during the pandemic, and tried to highlight what the issues have been for women, persons of color, and other groups. So we look forward to learning more about that. Right now, we are seeing the great depletion in terms of energy. People are really out of energy. Burnout is rising at an unprecedented rate. So I'm sorry, I think, Katherine, you said your burnout rates are up, but you have company everywhere. This is what we are facing right now. And we have to get our arms around that and figure out ways to be very, be able to pivot quickly and be creative and effective about addressing that. We're doing a lot of work in moral injury. We have a podcast coming out on that in a few weeks with Drs. Dean and Talbot, trying to develop some very nimble measures that can be used to get senses of where the moral injury is and what to do about it to prevent it. In preparation for this talk, I got interested in compassion fatigue. I don't know much about compassion fatigue, but I read about it over the weekend, was fascinated by that literature, and seems to be traumatization of helpers who are helping others, and at some point you just get exhausted. So it clearly overlaps with burnout, but not unlike moral injury, it's not the same construct. So I think we need more work there. The gender equity piece, we've had articles about this for 20 years. We all agree it's present. It's time to change it and make it go away and to put some interventions in there that make this equitable. And I think in terms of equity, we have work to do in terms of equity for our racially minoritized workers as well. And so studies in that area will be important. One area for equity we're working on is trust. I think, Katherine, you were the one who mentioned the trust article that came out in Annals of Family Medicine a couple of days ago. We do want to start looking at trust in different populations. I don't think the measures that we have are going to do it. I think we have to develop new measures that measure experience even better. And then finally, some implementation science, which is what we've been hoping to do for a while. I find a great hunger out there for the kind of work and data that we've accumulated over the years. And I see health systems that want to develop an infrastructure, measurement, evidence-based interventions, monitoring, leadership, burnout reduction, all territory for new randomized trials, and learning health systems so that we can learn better how to organize the care that we give. I don't know if I took too much time, Bob, but I hope not.
Never too much, just right. And I knew we were going to be tight on time, but that's okay. This has been such an important discussion. And thank you to all of you who are throwing things in the chat. There are some things in there I'm going to do tomorrow myself. What I'm tight on is I want to give one more go round, a speed dating go round to all of our panelists, if you don't mind, to sort of reflect on now what you've heard everybody else say, what you've heard Mark talk about, some of the things you've seen in the chat. So Katie, can I turn to you? Are you able to connect okay? Do you want any reflections from you, a minute of sort of some speed reflections from you about what you've heard and what you think about it?
I think we've covered a lot of different, both personal and structural. I think one thing I was just reflecting that we haven't talked a lot about is the whole electronic medical record and the administrative burden. Because I think as long as that continues to grow, it's going to be hard to counter it with other measures. So that's something I think is really important going forward, and even to think about in terms of legislation that reduces the burden and the administrative burden, particularly in primary care, where we're just getting slammed by one thing after another.
So
thank you, Lindsay. I have to say I'm a bit of a fan, so I feel a little bit like a movie star groupie here, getting to be on a panel with you.
Well, we're so pleased that you could join us, and thank you for your terrific remarks. So Lou, I'm going to turn it over to you now. What are your reflections on what you've heard and what you've read here? What are you thinking?
Yeah, no, it was great to listen and learn. I think for me, it was just validation that there's a lot of great work already out there, great frameworks and conceptual models that we can really try to anchor our work at Columbia, and to Mark's point, then do the customization so we can have the true Columbia experience, and then share and publish as well.
Terrific. Thank you, Lou. And Claude, your tree was a big hit. So I think we got to get that published and out there. A lot of people are looking for the tree. I want to grow that tree. So thank you for sharing. I'm sorry, I didn't mean to put you on the spot by saying we could share it. It's not any place yet, but we'll work on that, right? We'll stay in touch on that.
I've actually sent you something that can be shared. Thank you.
Terrific. And thank you. And Joelle, how about you? Thoughts, reflections on now you've heard across the presenters and the reactions in the panel?
Yeah, I think I can second what Lou said. There's so much information. There's so many people doing so many pieces to really look at the collaboration, and I value everybody writing in the chat. But I think the biggest thing is we know well-being is a lifelong process. We're never going to be at the top of our game. We're always going to be studying and evolving and looking at different aspects. So it's really hopeful, and I look forward. And all of you should know you're in this together, right?
Indeed. And actually, I feel better just actually hanging out with all of you and talking about this. There's a little bit of a peace has come over me, just the fact that we are in this together, and there's a group who can really support each other. So I appreciate that. We're just about at time. I don't know, Mark, do you want to bring us home with sort of some last words here about your wisdom over the ages and what you've heard and what you're seeing from all of the folks who have joined us today?
Well, I was just feeling the way you were saying it, Bob. Whenever I get a Zoom team like this, I feel like it's a dream team opportunity. All these people who care about this, and it's going to take every one of us to make this world a better place. And again, with AHRQ support, we have a chance to make a difference. And I can't think what would have happened if you hadn't helped move this work along. So I think just seeing all the people here with interest and dedication to this just makes the rest of my day. So that reminds me that a thing I always like to close with is 3 good things. People know about 3 good things from Brian Sexton at Duke. Whenever I'm in a meeting, which is, it doesn't work here because we're all having a good time talking to each other, but when I'm in a meeting where people are really heavy about something, I say, let's do 3 good things. And they look at me like I'm nuts. And I say, no, really, let's do it. And you just do it and start talking about the things that were good in your day. Like I always say, my son goes to work at 6 in the morning, but he can't wake up well. So I call him at 4:45 and wake him up. And he says, thanks, Dad. And it makes my day. So, you know, we've all got those things in our days. And whenever I recall them, I just feel better. So seeing you all makes me feel better. That's my good thing for the day.
Well, that's a great way to bring us home. So before I thank the presenters, I just want to let anybody who wants to stay on know we're going to do a part 2 just to reflect on what we've done over the learning community over the last year. No need to stay, but I do want to make sure I thank very clearly Dr. Katie Gold. Thank you for joining us from Flint, Michigan. So appreciated your remarks. And I had my Kleenex handy, but you did great. Dr. Lou Baptista and Dr. Claude Mellons, thank you both so much for sharing your success story at Cope Columbia and the tree. Wow. Joelle Monaco, thank you so much for talking about the organizational things that need to happen. And Dr. Mark Lindsay, thank you. Really appreciate that. So with that, everyone is free to go. If you want to stick around, we're going to pause for a moment and then just to do a little presentation on what we had heard over the past year. So thank you all for joining. Arlene, did you want to jump in with any last word?
Oh, no, this was fantastic. It couldn't have been better. Thank you all.
Indeed. Thank you all. We'll hang out, but feel free to go. You want to back up one, Elizabeth, just to make sure we've got the, okay, great. Just to set up the transition. Thank you. Appreciate that. And so let me just keep it rolling here. So I know this is the hardcore, those of you who have been willing to stay. So thank you for that. What a great discussion. I'm still on a high here. So the adrenaline rush is pretty good. So forgive me if I'm feeling a little chatty here, but part 2, we wanted to spend 15 minutes. This was our last learning community session of this particular initiative. And as Arlene, as you said at the outset, we've learned so much and we have other things planned for the future. But I thought it might be useful for us to share that we heard you, some of the things that we heard and what our plans are to do next. So now you can go to the next slide there, Elizabeth. So really, we heard a lot of things that were both challenges and then really innovative responses. Some might even call them heroic responses by primary care during COVID. And we heard them in sort of these, we bucketed them in sort of these broad areas of patient-centeredness, things around clinicians in practice, systems and infrastructures, and then community and public health. So for example, in patient-centeredness, we heard a lot about how the pandemic was exacerbating socioeconomic and health disparities, but that really primary care was doing things to try to address those. We heard stories about mobile visits or home visits or parking lot visits to allow people to continue to get the care and address some of those disparities, including assistance for social needs as patients were losing wages and insurance. Primary care was also delivering more and more mental health services because the pandemic has led to an epidemic of social and behavioral and mental health needs, and primary care was working hard to address that. It was more difficult to provide chronic care and preventive care. We heard about how creative primary care practices were being to continue to see patients for those chronic conditions and address the impact of COVID on some of those conditions sometimes through telehealth, sometimes through other ways of making visits to maintain that continuity, as well as to work to coordinate that care. From the clinician and practice side, we heard about really innovative ways to improve access, even though that people were losing revenues and staff were not often losing staff in the office, that practices created flexibility around community needs. They created some new models for vaccine distribution and really worked hard to make sure that people who needed that access could get it. We heard about challenges around personal protective equipment and that what practices had to do to address those limited resources. We also heard a lot about clinician burnout, and you just heard today, I think, a really nice demonstration of what some of those key messages were and how many practices are really working hard to build in resiliency and creating mental health programs or connecting staff with some mental health programs and behavioral health programs to help address those. From the system side, we've talked a lot over the last year about telehealth. That has been one of the single biggest challenges for transition. We had a whole panel, and I see Teresa Wellness on the line, and she moderated that discussion, a terrific discussion. Actually, it was our most popular session of the past year, was the one on telehealth, and really how important it was to help practices transition to those new models for delivering care, and then how we address some of the financial challenges there as well. And then lastly, just around community and public health, we had two terrific presentations around, one around connecting primary care practices with public health organizations. And I think Howard Haft, who was on the call for us, really provides some nice discussion about how you build in the connections between primary care and public health, and really some of the essential partnerships with whether they were for federally qualified health centers, really looking for how to do partner with public health to address population needs and other opportunities and innovations like that. Really, and then mostly with the connection with public health about how to be engaged more fully in the response to the pandemic, because we heard how much primary care has to offer and yet was often not included in the pandemic planning and the connections with public health in many states. So that is just a sampling of some of the things that we heard over the past year. We're taking all those learnings, we're trying to put them into a manuscript that will include anonymous quotes from some of our sessions, really try to make sense of the thematic things that what we heard, because we think this is a message that the rest of healthcare really needs to hear, is that in the midst of paying attention to ICUs and acute hospital admissions and things like that, that primary care really stepped up and under really seriously adverse conditions contributed so much to the health of this country during the pandemic. So those are just a few of the reflections that I think we wanted to share. Let me just pause there for a moment to see if anyone wants something to offer. Those of you who have stuck around, and Jane, thank you for sticking around, and Teresa, Lauren, I see David, a few others. Anybody want to reflect on anybody who's been to any of these sessions, what they heard or what was valuable to them? And silence is okay too.
Well, this is Jane. You know me, I always say something.
Excellent. Thank you, Jane. I knew you would come to my rescue.
I really did enjoy today. I've been, I was texting a little with Arlene. I've been playing around with this concept of organizational resilience and how our efforts around quality and safety either do or do not support it. And so there's just, I think we've really learned a lot, and there's just been such good discussion. I know I'll take away a lot from it, but there's a lot more to learn. And I think one of the things that I'm starting to realize too, that we have to factor into all of this is how much our outside world is changing along with this. And I think we've been, thinking about with COVID, all the craziness that's been happening within the healthcare system, but now all of these workers, and caregivers within healthcare go out into a world that's getting more and more feeling unstable. Things are changing so quickly. And so I think we have to figure out how to factor that in as well. And I don't know exactly how to do that. I think we've touched on some things today. But it's not all about individual wellness. It's really about, how we we have to really think about how we structure our systems differently. And that includes teams, leadership, how we utilize resources, and it's going to take a while. So a little bit rambly, but that was what was on my thought after listening to everyone today.
Thank you for rambling, Jane. And I think that message came loud and clear for me too, is these are institutional solutions and really organizational ones. And it's not about an individual's own resilience or strength necessarily, but how they're supported by the institution. I think that was a great message to hear, and appreciate you reinforcing that. Anybody else want to reflect just on sort of either today or the past year? And I'm looking at Teresa just because I always pick on you, Teresa, but are there others who want to reflect? And that's okay. Did you want to say something, Teresa? Because we're not hearing anything. It's okay. I'll tell you what we're gonna do. I'm gonna just try to wrap things up a little bit now. And if you can, oh, actually, I need to call out Jennifer O'Rourke, because Jennifer, you've been on the, I got your microphone problem, got it. You've been on the chat, Jennifer. So thank you so much for being on the chat all day. Great comments out there. If we go to the next slide, Elizabeth, we'll just sort of wrap this up. And I just wanted to reflect and for the, even though most of them are not here, here are all the people who we had speak at our various webinars and sessions over the past year. Really terrific group of people who offered amazing insights, and it doesn't even include the folks we heard from today. So I want to make sure in the ether we've said thank you to all of them. And then very last slide is just to say thank you to all of you, those of you who have hung out with us, and this includes the AHRQ team and the NORC team and everybody else out there. And with that, Arlene, I think we're just about at a wrap. So I will give the last words to you.
So just what I want to say is please reach out to us. We want to hear from you. Tell us what worked, tell us what didn't work, tell us what we could have done better, tell us how we could meet your needs, send us your ideas for our primary care work. We really do want to hear from you.
Couldn't agree more. And, you know, Lori or one of the NRC team, can you put the email for the learning community in the chat? And then just so folks have it. And thank you about the slides. You know, we are working on creating a whole website that has all of the things that we have done over the past year that will be easily accessible. So we've got all of everyone who's registered and participated in one of these. You now are our community. We'll stay in touch with you. And as that information becomes available, we'll send you so that you can find places where you can find the slides, you can find the recordings if we've got a recording from it, and continue to engage with us. So thank you, Elizabeth, for putting the email in the chat. And then of course you can reach out to any of us on staff. So with that, I will make one last round to see if there's any last words from anybody.
If I had one last thing, this is Mark.
Yeah, Mark.
I just want to resonate with the organizational resilience construct. There was an article in JAMA a few weeks ago about it. I thought it was brilliant. And I think it's really important that we've learned how important it is to be able to pivot quickly and know where we're going. And I don't think organizations are built for that. And then in line with that, I think if we could start to measure how many organizations have burnout on their organizational dashboard now, and then let's see how many next year and the year after and the year after, because that is essential. People don't seem to understand at the highest ranks of most organizations that you can't grow, you can't recover, you can't respond if people are terribly burned out. You have to address the burnout first, and then you can grow again. So if they don't see it, they won't know.
Great point, Mark. Great way to bring us home. Any more last comments? Last call. We're shutting it down. All right. Well, thanks again for all of you for joining. Good to see your face, Jennifer, too. You're prolific in the chat, but always nice to make the connection in person. Thanks, everybody. Appreciate you joining us, and we'll be in touch. Take care now. Bye, all.